Um, Meeting is being recorded. Continue. So I'll make this very brief. I've known Dr. Johnson for well over 30 years, maybe 40 years. And it's really a pleasure to present him. Kevin is the Cornelius Vanderbilt Professor and Chair in the Department of Biomedical Informatics and Professor of Pediatrics at the Vanderbilt University Medical Center. Kevin has had a distinguished career. First undergraduate at Dickinson College, medical school at Johns Hopkins, where he rose to be the first African-American chief resident in pediatrics at that storied institution. Kevin went on from there to receive training in medical informatics at Stanford University and has risen at Vanderbilt both administratively and after being on the faculty at Johns Hopkins, risen in unusual ways where he's served as both chair of medical informatics, at one point chief information officer of Vanderbilt at the medical center, and supervised their transition to Epic, which I think anyone could tell you is a completely hair-raising experience. Kevin has many interests and is both a researcher as well as an interpreter of medical informatics and science to the world at large through documentaries, through podcasts, and he also has had a tremendous role in education and public service through the Robert Wood Johnson Foundation, the National Academy of Medicine, of which he was elected to membership, and many other venues. So he's a cherished teacher, educator, researcher, and it's really our pleasure to have him and host him virtually at Penn.
Well, thank you very much, Brian. I have to say, I expected nothing less because Brian knows that I have all of the old pictures of him. And so I appreciate the nice words. And it's a pleasure to have a chance to talk with everybody here about something that means a lot to me, which is how do we bring together this triumvirate, if you will, of patients, providers, and data to really enhance and improve clinical care. The graphics that you see on this slide will make more sense as we progress. I love movies, so I always have to find at least some excuse, and I think you'll see why I decided to do it. I decided to start today with a little preamble to set up the talk. Not everybody who's on this call is familiar with electronic health records, although probably all of us have been patients at some point. But suffice to say that post the era of the Affordable Care Act, there's been a dramatic uptick in the availability of electronic health records in office-based practices. The national data now, this is data from ONC, show that we're between 80 and 85% adopted in office-based practices. There is some geographic variation to that. But by all accounts, many of us who've been on this journey for years breathed a sigh of relief as we saw this happening. This was one of the exciting parts, which is the fact these are some data from 500 rheumatologists, 500 patients seen in a rheumatology clinic. And this is just one view, high-level schematic of what we've gained. At the top are claims data, which is what we had traditionally used for most of health services research and improvement until the time of the EHR. Now that we have the EHR, that claims data is officially the tip of the iceberg. We have both the breadth of claims data, but significant depth in some of the areas that you can see here on the left. So it's an incredibly exciting time. And when you start to think about what we could be doing with this in data science, it gets even more interesting. In fact, if you go back a few years to 2009, Dr. Bill Stead and Herbert Lind, who's an engineer, spent some time with the NRC developing what I think is a really seminal report that's worth a lot of reads that talked about computational technology for effective healthcare and what we needed to do at that point, as well as what we've needed to do since then. And what I liked about that report were these two paragraphs, these 9 points that I put here on the right, which is a focus on improvements that are evolutionary, meaning essentially incremental gain, incremental effort, but also recognizing that this technology gives us an opportunity for the radical change healthcare needs, i.e. small amounts of effort, or if you will, large effort, for much greater than 100% return. And so I think this is very exciting, and we're beginning to see how if we could align certain types of care, this could happen. This is in no small measure due to a lot of work, informatics, and a lot of colleagues from Penn and really every institution around the country. I was a part of the reports from the Institute of Medicine, which are shown here in 2001, 2004, and 2007. And we were able to get these reports published and advise Congress and really the federal government because of research that had been done in informatics for more than 30 years, a lot of which had been done in the prior 10, and of which I had a small part to play in that demonstrated the value of the EHR, both because of how we communicated to the scientific community, as well as how we communicated to lay audiences, but also because of our own direct involvement in health policy. Unfortunately, where that's left many of us, or some of us, is a fairly sad state in terms of how many people may appreciate the value of electronic health records as they exist currently relative to what we aspired to have happen. I started to understand that very, very well about 4 years ago when I was asked to lead the transition at Vanderbilt from our homegrown electronic health record called Star Panel to a version of Epic that we've created called eStar. That transition involved 3 years of incredible hard work, as you can see on the bottom left of the slide, from thousands of people at Vanderbilt. And if you look at the upper right, there was an amazing release of energy from a lot of those people as we went live with Epic on November 2nd of 2017. There were also a lot of happy IT people and a lot of informatics people. But as always, there is what's called a J curve to the adoption of a commercial EHR, where satisfaction starts at one level, typically drops dramatically over the first 6 months, and then may or may not get back to where it was, if not higher, over the ensuing year. That picture from the bottom right is actually a video that we created called Living Through Going Live. And if any of you are interested, I'm happy to send the link. It's on YouTube. We spent a lot of time actually following our go live through 1 year after go live, just to experience the J curve in a much more kind of visceral way. Because a lot of people simply have never experienced anything like this, and I think it's pretty instructive. What was really instructive for me was that Carl Dvorak, who is one of the heads of Epic, called me on the day of go live and said, well, congratulations, now the hard work begins. And at first, I laughed and I, kind of played it off because I recognized what he was probably thinking about was managing the printers and things like that. But the more I thought about it, the more I really understood what he said, although not at all in the way he meant it. So this slide shows a lot of the work that's gone on at Vanderbilt. The left side of the slide represents approximately 1991, and 2017 is where you see eStar. What you see in blue are clinical applications that we built ourselves. What you see in brown are the ones that I had a role in. What you see in kind of the coral peachy color is research components that we built, some of which I had something to do with. And then in green, we were able to take some of the exact same methods that we use to create the tools that you see in blue and create a component for our educational environment at Vanderbilt. All of that work came to a screeching halt in 2017. We then ended up with what was a fairly basic clinical app that had the functionality we needed across the board, meaning some of these applications that you see here weren't used everywhere at the same level. Now everything is used everywhere at the same level. But we had to leave some things behind, and we're now, as you can see to the right of it, starting to take some components that I'll explain a little bit about today and reconfigure them and reimagine them for a new future. And that's why I decided to stick this in. It's very much a back to the future moment. And for me, that back to the future moment has three major areas: documentation systems, medication management, actually four: health information exchange, and precision medicine. And in all of those, I want to describe a little bit of where we've come from, as well as where I think we now need to go. So back in 1987, this is my entering internship class at Penn, and you'll be able to find me without too much difficulty. I'm sorry, at Hopkins, you'll be able to find me without too much difficulty. Back then, my vision was that we would have ubiquitous access to all patient data. We would have integrated and direct data capture. We would have real-time clinical decision support. I had heard stories of this and thought it would be a really nice thing to have. And we would, more importantly, have secondary data that could have secondary uses across all the enterprises, whether it be undergraduate engineering, graduate computer science and engineering, all the way through medical school, nursing school, allied health professions. These data were just a rich treasure trove. We all knew that that was a possibility. So let's start with documentation. The question I addressed early on was, how do we make encounter data computable? Because at the time, most doctors used what you see in the background here, which is dictation as their primary method. If they didn't use dictation, they were using very, very small, short notes that conveyed just enough information to essentially keep you out of court and to help remind you when you saw a patient what you did the last time. They were no use from a secondary perspective. And in fact, they were not always of great use in a primary perspective if the patients came back, without going into a lot of those details. And so what we all had kind of envisioned was, if we could take the dictation and somehow codify it, which in the NLP parlance would be called a late binding strategy for generating coding. So you create a note, you then use the information from the note and apply to that information custom classifiers, extraction techniques, parsers, and ways to derive and impute more information than the note itself might even have contained. This was the strategy all of us wanted to do. And when I was at Stanford, I started embarking on a project that used that strategy. The other strategy is the early binding strategy, which essentially is when you start out with an ontology, which is essentially a worldview that's comprised by both relationships and terms that are brought together to describe an environment. You take the ontology, you pull away the terms and all the pertinent concepts and attributes, and you're left with the components that you could then use to create a user interface. That user interface is what people work with. And as they work with it, by definition, you're getting fully computable structured information. You now have to create natural language generation tools to create a note that would be useful for other people, where the metadata are hidden and the note remains. So this issue, this tension between NLP, late binding and early binding has been an ongoing area in documentation, and we'll talk about where that's going now. I started out by saying the quintessential late binding exercise is to see whether we could get patients' histories by allowing them to use speaker-independent speech recognition technologies and using, at the time, a model that had an embedded vocabulary that was hidden from the user. DARPA had been doing a lot of work in this space, and one of the things that DARPA had uncovered was that it was more difficult for people to understand the grammars that drove speech recognition than it was to actually do speech recognition. So our goal was to try to hide those grammars. And the way that we did that was made a history-taking system for back pain and used an augmented transition network that allowed us to ask open-ended questions to obtain the speech files that are being generated by the user, to do late binding to identify concepts. If we instantiated sufficient numbers of concepts that we could get all the way through the diagnostic question asking, then we would skip questions. But if we didn't, we had successively more simple questions that we could ask to actually constrain the grammars further. And what we were able to demonstrate by doing this exercise, which is reported in a paper in AMIA from that time, a program called QMID, was in fact that we were able to get about 72.5% utterance recognition. So things that patients said based on very generic prompts, we understood 72.5%, which at the time we were quite excited about, because this was essentially speaker-independent, context-free dot recognition. And then as we started adding more and more constraints, we were able to increase the utterance recognition rate, the word recognition rate essentially, and the utterance semantic accuracy. And this study was one of the few that we were doing as a part of the DARPA, what's called the speech recognition programs, to show that we could do these grammar-free speech recognition projects. But it was extremely onerous, and 72.5 utterance recognition, even with the work we were able to do to semantically improve that, was never going to be good enough for healthcare. And so this was a project that we knew we could revisit, but at the time the technology really wasn't there. I then got a chance to go to Hopkins. And when I was at Hopkins, we had no electronic health record. And so one of the first things I did was work with the team to build this system here called EPR 95. A few people on the call who are from Hopkins might remember this. We built a basic electronic health record. It has all of the usual types of sections that you would find in an electronic record. Plus it has a problem list, it has a medications list, it has allergies, and it has visits. To take this record and make this very useful, we needed to try to do as much of this binding to things that were computable as we possibly could. And I wanted to focus on documentation. So I developed a program called Clicktate, which was one of my cleverest names ever, dictation with clicking. And the basic idea of Clicktate was to create our own little ontology in pediatrics for well child care or health maintenance visits. And that's what we call the components library. To then take those components, extract them and put them into templates, and then using the program, bring up a specific template and a specific output format, allow people to record the patient's history, physical exam, etc. Take those raw data, store them in another file, and then have a document that would go in the medical record. This is a screen snapshot from Clicktate. You'll find it looks incredibly similar if you've seen what Epic and Cerner and other EHRs have to the systems that we currently use, which essentially was minimal use of the keyboard. So by clicking, you were actually creating a note, and each of these terms itself was codified. The templates were age appropriate. And if you looked at the note preview, you could get a general sense of what was actually going to happen as you went through the process of creating a note. This system was implemented inside of our pediatrics clinic, and you can see here a much younger version of me playing the role of a patient with one of our residents, showing how the goal was for the terminal, the computer, to be between the provider and the patient, and potentially family members who might have been to my right, and that we instructed very carefully how people should use computer-based documentation during the visit. It's very important in situations like this to spend a lot of time with this adoption piece. So how did it impact communication? To do that, we actually set up video cameras and recorded visits in a fashion that was blinded so that people in the room knew what was being done, but we audio taped and videotaped and then analyzed the audio tapes separately so that it wasn't clear which ones might have been conducted using a computer and which visits were conducted using regular sort of paper-based processes. Two of my collaborators on this project were the head of our clinic, Janet Serwint, and a woman from the School of Public Health who's well-known, Deborah Roeder, who is famous for creating the Roeder Interaction Analysis System. The goal of this project was to determine whether computer-based documentation versus paper had an impact on verbal and nonverbal interactions. These were essential data for us to get to scale the idea of computer-based documentation throughout both pediatrics and all of medicine. And what we were able to find was quite positive. Computer-based documentation visits were slightly longer than control visits, but when we controlled for that length, we actually could find essentially equivalence, no difference, with adequate power to detect up to a 10% difference between control and computer-based documentation. The visits were associated with a greater proportion of open-ended questions, which really surprised us. We think we know why, but it really surprised us, as well as more use of partnership strategies, greater proportions of social and positive talk, and a more patient-centered interaction style, probably because people were conscious of using the computer and trying to avoid it while they were seeing patients. Nevertheless, this was the beginning of a series of studies done by both me and other investigators to see the extent to which we could bring computer-based documentation into the exam room. One of the things that we discovered fairly quickly, though, was that if we started to work in the space of early binding, i.e. trying to come up with an ontology to represent a set of visits, there was going to be a major issue with search space capability. This is 3 different types of clinic visits that were published in this paper here. This represents the typical searching problem when you're using computer-based documentation through a visit for a diagnosis that was known essentially at the time of the visit. So a patient in pediatrics who comes in with ear pain, or a patient in neurology who comes in with a known history of a particular type of seizure. In this case, there's a number of questions that we can ask at the very beginning, but as we ask more and more questions, it's pretty clear where this is going to end. And so the refining of the story becomes very easy to simulate and emulate in the template. In contrast to that, patients who had clinical practice guideline-based care, so health maintenance encounters, typically had an equally robust template from the very beginning to the very end of the visit. Where it got really challenging was when we were trying to do chief complaint-based encounters, and where we uncovered that patients who had a fairly routine set of possible ways to present with a disease, let's just say abdominal pain, could potentially have these asymptotic moments. And the classic example would be a patient with abdominal pain who it turns out has depression, where this template is simply not going to be adequate from this moment on. And so we started exploring, going back to this model that I just showed earlier, where we brought up essentially the entire ontology and created templates on the fly. This was a project that was used at Vanderbilt for almost 10 years. It started out as the name Quill. We ended up changing the name. And what you can see here is this is an entire interface terminology for patient care. By selecting different components and actually filling in different attributes, we were generating specific notes for the patient that you see here on the right. And all of this information was both computable and entered into the electronic health record. But as you might imagine, systems like that were incredibly tiring and onerous for those people who were using them. So while we had a very high level of, a very early high level of adoption, we actually had less and less adoption per year. So again, teaching us the importance of trying not to overly involve our physician colleagues in getting data that will have ideal secondary use. So one of the questions that we've been thinking about quite a bit now with the computational power we have and with tools like Epic is, so what if we actually didn't need to document? What if we could start to think about the use of other technologies to help us with that? Well, one of my students and I have been working on a project called Breadcrumbs, where we are essentially using the audit log that comes from an electronic health record to identify which parts of the documentation that is required under E&M coding, evaluation and management coding, we could essentially generate just by the use of the EHR without actually generating a note. And this is an example of some of what we see in the audit log. We've taken audit logs and we are abstracting those into what's called a clinical audit trail by having a set of standardized patients use the EHR with providers, and then by looking at the video and the audit log, identifying the actual tasks that are being done during the visit. Based on that, we can map that to the note and show that if you go across, this is the typical note that would be created for those patients after having been followed by a standardized patient. These are the components of the audit log that turn out to be relevant. And without getting into all the details for this audience of evaluation and management coding, we were able to use our log file to generate many of the sections of what would typically be required in evaluation and management coding. Those parts that we couldn't evaluate, you might have noticed in the other video, the other screen, were places where people were going to an exam table and actually seeing the patient. So the question then comes up, well, if I showed these pictures, these static images of an exam to most clinicians, they will be able to pretty readily appreciate that this is probably a patient who's getting some neurologic exam, probably a shoulder shrug, visual fields, and then may or may not be having their heart listened to or their lungs listened to, but something's happening with the stethoscope. We also know in a video how much time each section's taking, because we obviously have static images over time. And what's been very interesting is that there's been work that's been started by Paul Tang at Stanford, Fei Lee and me, to look at whether the work that she's done with supervised learning of images could be applied to a corpus of medical images that would then allow us to automate generating a document from a video. What's very interesting about that is that if you look at some of these are obviously, this is very early work that she did, and I always show this because some of them are great and some of them are hysterical. But you can imagine that those are fairly robust concepts. And if we are now able to get the concepts from the video and to get the concepts from the audit log, it may be possible to have an equally rich document that is generated at least semi-automatically, if not completely automatically. So this is an area of research a number of people around the country are playing around with. There are some companies that are in the area, but they're in no way trying to do the work with image analysis. So we'll see where this goes, but this is sort of the direction we're imagining beginning to pursue in documentation. The next thing I want to talk about is medication documentation. Many people may know that the medication list and medications are possibly the most important component of the electronic health record for the average patient. However, we know that there are tremendous problems with paper-based prescribing. Luckily, these have mostly been mitigated by the use of electronic health records, but not in any way completely. And electronic health records have introduced new errors, something that Ross Capel at Penn has often described. So there are up to 21% of paper-based prescriptions that have errors. There's inefficiencies in the pharmacy, and there's a number of preventable adverse drug events that happen even today with electronic health records and with medication lists. Newt Gingrich, who had very few things to say that I really enjoyed, but one of the things he did say that I thought was great was paper kills. And in this case, I think he was right. It was really time years ago for us to move away from e-prescribing. At Vanderbilt, we actually built our own e-prescribing system. This was one of my big projects. As a pediatrician, we paid a lot of attention to pediatric-specific parts of this. And you can see that we had a set of different alerts that showed up. I won't go into all the details, but this is a typical e-prescribing system. What was very interesting, though, was that in this particular patient, we were getting a dose alert. And the reason for that alert was that we were unable to use this strategy of giving 50 mics per ml of an oral solution for a child who's 22 kilograms, and to get the right dose without having to split the mLs or round the dose, which led us to the question, what do people, what is it that most people do? Sorry about that, my slide didn't do what I thought it was gonna do. What do we do to help out this sort of a picture? And I'll come back to that. The other thing that we were able to do was to deal with some issues that were happening in the state of Tennessee. Tennessee was a state that had one of the lowest generic prescribing rates of any state in the country. And we had an idea of a very simple fix that involved very simple human factors engineering, which was simply to take the medication that was being searched for, and once the search was resulted, to return the generic version of that medication with the brand name below. So one could click on either one. And this very simple intervention had a very dramatic change in our generic prescribing rate, with no loss of people's satisfaction using the system. And because medications are renewed using what was prescribed before, you can see that the generic prescribing rate continued to go up. It never went down. And at that point, we went from one of the lowest in Tennessee to the top 5 in terms of generic prescribing with this one intervention. And these are the types of things that we see over and over, just the ability to engineer the system of healthcare to deliver the outcomes that we want using electronic health records. So this is the example I was talking about before, where we have a dose alert, and it's not completely clear to a provider what's wrong. So we were funded to create a project called STEPstools, which stood for Safety Through Electronic Prescribing System Tools. And essentially, this is a multidisciplinary group of pharmacists. Bob Grunmeyer's in this slide, I just realized. I'd forgotten about that. Pharmacists, pediatricians, EHR vendors, and we all had all of our meetings at state parks, or national parks, which I highly recommend as a way to have a meeting for a big grant. And what we did in this project was essentially create web services to improve pediatric prescribing. We created a web service that accepted the patient's weight in kilograms, age in months, the name of the medication, the code for the medication, because we needed to have computable information around ingredients, the milligram per kilogram dosing formula, and the frequency, which we could derive, but if we received it, we could actually be even faster in returning a payload back to the e-prescribing system. Rather than going through the complexity of the slide, I'll try to do it quickly, and then I'm happy to answer questions about this project. But essentially, we took medication formulations that were known to be available through a controlled vocabulary called RxNorm. We took the information that was provided in the web service and information that we had already derived for the top 95% of medications in pediatrics so that we could have rounding tolerances, and then combine this with these information to generate a working range of possible doses for the patient. We then converted those working ranges into dosage ranges based on the formulation that you see here on the left. And then from there, having generated the doses, we scored the doses, and then based on the scoring algorithm, which was heuristics based, Things like certain children at certain ages should receive liquids, so doses that are liquid doses should be preferred. Children tend to prefer fewer than 10 mLs of liquid at any one time, so more concentrated would be better. We then were able to identify the optimal dose. The optimal doses were then sent back to the EHR as another web service payload that then populated the electronic health records e-prescribing system and essentially allowed us to automate the entire process of dose recommendation. This is a study that we did to determine the extent to which those doses were, generally speaking, well received or not well received by pediatricians. And what you can see here is there are bars in gray. Each of the bars in gray represents a step stool recommendation and the number of pediatricians who had a chance to review this and who felt that this was the dose they would select. We also provided a series of non-step stools generated doses based on real use cases. You see the percentage of time those were selected that are here in this hashed mark. And what we were able to see in this study was that about 60 to 70% of the meds that people selected were the doses that were developed by step stools rather than the doses that other providers had given us that would be other alternative doses. And the point of this was to simply say that we believed step stools was going to be safe. All of the information from the step stools project is now in the hands of the American Academy of Pediatrics, and we've actually sold the technology to a company that's called RX Review, and they're in the process now of implementing this with an Epic. So we're really excited about where that's going to go. It looks like I'm doing pretty well for time. So let me just take a minute and show you another small video. Hey, Brian, if you could give me a thumbs up if you can hear this, I'd appreciate it.
No, I can't. I can hear you, but not that. Yeah.
And I'm all about skateboarding. I also have cystic fibrosis, which means I cough a lot, wheeze like crazy, and get all kinds of lung infections that put me in the hospital. So my mom's always on my case to take my meds and digestion enzymes whenever I eat. She doesn't like to let me out of her sight. It's like, get off my back already. Okay, so maybe I forget my meds now and then, but it's my life, isn't it? So I've been begging her for a phone ever since I started 6th grade. I mean, all my friends have them. Then, the other day, I had an idea. I was taking all 20 million of the meds I need to stay healthy and thought if there was one thing they'd go for, it would be something that helps me with CF. So I do some Googling and find the site called Biomedical. All you gotta do is use this program on your phone, and it reminds you of all your medications that you've gotta take and when. Sure enough, Mom was psyched. So I get the phone, and my mom helps me put my med schedule together. It works with my personal health record, so there's not a lot of extra work to do. I choose the meds from a list and drag and drop them on the day and time I need to take them. I bring my phone with me everywhere, just like my skateboard, but it does take me a little while to get used to. Like Friday night, I'm over at my buddy Jason's house playing on his console when my mom calls. She just got a text from my MediHealth saying I haven't taken my antibiotics. I look at my phone and see I missed the alert. I take the pill and press a button to show that I've taken it, and she gets another text saying I'm all good. So at first, my mom's still on my case. But the cool thing is, my MediHealth shows her and the doctors that I'm taking most of my doses now. After a while, she starts to realize that I'm on it and loosens up a little, so I can actually have a life. Like, my cousin Paul lives in LA, near the best skate park in California. He's 25, and the whole reason I started skating in the first place. Ever since I can remember, he's been saying I should come visit him. My mom's always been like, he's not dependable enough to help you with your meds. But when he called this time, she said, well, okay, as long as you take your phone.
So this was a project that was actually funded by Robert Wood Johnson and AHRQ to develop what became the first text message-based medication reminder system. The code for this has generated more companies than I'm actually able to tell you. It's been in Creative Commons for a while, and it did very, very well, especially when we first released it. And this is just a little screenshot of a piece of this. My MediHealth essentially allowed, this was an early, actually I think it was version, this is all 2007 work, so this was when the iPhone was first released. And we essentially used natural language processing to allow any arbitrary text that was given to, well, not any arbitrary text, but to allow text that was responding to us giving patients a medication alert to come back. So the keyword was my mutt. You could say things like S, you could say skipped it, you could say all sorts of versions of skipped it. As you can see, highly constrained vocabulary, but we didn't have to provide much other than these shortcuts. And by doing that, we were able to actually manage the patient's medication alerts and then set them for later in the day, or escalate if an alert was missed. Pretty much everything that you saw in that part of the video. Again, not going into a ton of detail, but just to prove that there is detail. This is some of the sample input, and the way that we actually did this was through taking that input, doing some pre-processing, synonym replacement. Then we did syntactic and semantic tagging, which in medications is quite easy because medications have a very specific syntax, almost regular expression-like. From that point on, we simply parsed the information, sent the web service over, received back that this was or wasn't taken, used natural language generation, much of exactly what you've heard me talk about before, to communicate back and forth with patients. This was a study that was done that showed it was feasible. Just to go through, you can see that what we saw was a statistically significant increase in both self-efficacy and quality of life. The study was done with a fairly small population of patients, but we did see 7-day controller adherence go up. One of the big challenges that I know George and others know about is there's a problem with behavioral economics and tachyphylaxis with most smartphone-based applications. And I think the real trick to projects like this is going to be also figuring out how to make them sticky. So we were able to demonstrate that it works. There are now a number of companies that are using a number of different methods to try to take text message-based behavior change and make it sticky. Sometimes it seems to work, sometimes it doesn't, but this was a really exciting project. I also got a fair amount of press because we were doing work with children as young as age 5, starting with pagers to validate that this could actually be feasible. Learned a lot about medication management in schools, medication management in camps, and the kids who were part of this study were pretty upset when we had to stop it. This was work that we actually lost when we brought up EPIC that we're going to try to bring back. So what's next? Again, I think when we start to think about what we'd like to do to make medication management better, you have to recognize we've always had these 5 rights, which are essentially right drug, right dose, et cetera, et cetera. ISMP, the Institute for Safe Medication Practices, made a point of saying that the 5 rights were a destination without a map. And I think projects like the ones that we've talked about and other projects that we could do start, and I'm going to show you another one that I think might even be bigger, start us on a destination toward much better safety with medications. In the interest of time, because I want to answer some questions, I'm going to zip through just a couple of things in this next section here. One of the other projects that we did was recognizing that I didn't want to have people entering data more than once, but that I knew that for us to have the kinds of repositories we needed to do things like precision medicine, we needed to have interoperability. And in healthcare, you may know that although the data may be available for you in scattered places, most of the time, physicians don't look for it. In fact, one study in an emergency department showed that only 16% of the time was the medical record looked for, even when it was all available in the EHR in that facility, which points to the fact that we as physicians also have some education to do around the relative importance of looking for the information. And I could tell you lots of stories. So while one of the projects that we did at Vanderbilt that was funded by both our state and by the Agency for Health Care Research and Quality was developing a health information exchange. This exchange was a centralized server where data from all of these hospitals were consolidated. We then, this was the team of people who did that project. Mark Frizzy and I were the leads, and he was the lead for the development part, I was the lead for the evaluation part, et cetera. And there were a number of other people on the slide that are really, really valuable to this project. One of the first things that we had to do was to investigate models that would work in an environment where you have both not-for-profit and for-profit hospitals. And as many of you may know, hospitals tend to be aware of health data being both an asset and a liability. And so we created a model of a series of vaults. and then used an automatic record linking process based on a record locator service. So when a patient would come in, we would attempt to identify all of the records that that patient had across all of these vaults, create a mini registry, and then provide access to those data. And this is a model that now is being used, but in a number of places that continue to use central models for health information exchange. It's worth noting, many places are now using a distributed model, thanks to Epic and the system called Care Everywhere, which also works extremely well. But using this model, we were able to extract all of these information. This model had some very interesting approaches in terms of privacy preservation, in terms of patients who choose to opt in and opt out without losing access to most of their data. And so it's a pretty powerful strategy. This is a screen snapshot from the Health Information Exchange system. I won't go into a lot of details except to say, you can see here that we're combining from multiple locations data from this patient's complete blood counts. One of the things that we learned in this study was that over time, as you see more and more data getting brought into the system, we had a series of very specific usage patterns. And we had to separate out this one hospital, which I think we call Hospital K, if I'm not mistaken on the slide. Yeah, K. And this hospital had an amazingly high, relative to everybody else, usage for the HIE until there was a policy change that was related to people's nervousness about allowing nursing staff to have access to the HIE. And as predicted, their rate of use went from about 15% down to about 3%, literally overnight, and then was pretty much largely followed physicians from all of the other sites. So these were data that have been incredibly useful to the Office of the National Coordinator as we are now moving forward with interoperability in 21st century cures. I'm going to skip the workflow patterns part of this. We also uncovered different ways data are used by different providers. We were able to show that health information exchange resulted in a very clear ROI. Even with the amount of use that we had, we projected out that this more than paid for the cost of the exchange. And this is data that also turned out to be pretty valuable for us to see. One of the things that we noted in this project, which got me interested in the whole idea of documentaries, was that we were very unable to communicate to the public what we were doing with health information exchange, why it mattered, and why they should care, and what the issues were. Many of you may know that if you do studies, some of the studies have shown that 70% of patients already believe we have this technology in our hospitals. They believe that these data should flow and simply don't realize that they don't always. So we put together a documentary called No Matter Where that is now out on Amazon Prime and was picked up by Politico, and I had to send copies to everybody in Congress, and turned out to be a part of what was done to move forward with the interoperability work that's now going on. 21st Century Cures is a piece of legislation that's really an outgrowth of health information exchange among other projects. The idea being that this $4.8 billion that was given to the NIH for precision medicine, plus other money that was given to granting agencies, among other things, was used to try to leverage electronic health record data. And it was recognized in 21st Century Cures that delivery was going to be an important part of that. And so many of you have heard of interoperability, which is the ability to get data liquidity, computable data across boundaries of health systems. Information blocking is a term that's used to describe the phenomenon of charges or impediments to liquidity of data, typically around electronic health record vendors that may charge a certain amount or provide limited sets of data despite what may be in the EHR. And what 21st Century Cures is trying to do, and is doing that now in legislation, is to liberate those data and to eliminate practices that prevent data liquidity, which will essentially allow us to better get the data we need for augmented intelligence and machine learning. So how do we integrate AI and ML into care? So at Vanderbilt, we have a project that's now been going on for more than 10 years called PREDICT, which stands for Pharmacogenomic Resource for Enhanced Decisions in Care and Treatment. And it was, in fact, a lot of the work that's gone on with PREDICT and Vanderbilt that was the precursor to the All of Us program, which I think you've heard about. The idea in PREDICT is that we select populations of patients who are at high risk for receiving a drug with an actionable pharmacogenetic story. There is a known variant that if this patient has it, we should prescribe an equally efficacious alternative therapy. We then genotype all of these patients preemptively and have the data available in the EHR so that when someone is trying to order the medication for which this variant would suggest an alternative therapy, we can alert the provider that there are optimal other choices. So this is a very simple flowchart, which I'm not going to go through in detail, except to say that it's a tricky little project to go from the set of variants that we were able to receive in our production environment all the way into what we call drug genome interactions, rules that are within the EHR that would then fire. Here's an example of one of those rules. This is a rule for patients who receive a drug called clopidogrel. If they have a particular variant that makes, that's a rare risk allele that might cause, might cause poor metabolism of the drug, we send up an alert that essentially says that unless it's otherwise contraindicated, you should consider sending this patient home with one of these other medications. Although classic informatics work, it's always important to leave the original choice because computers are not smarter than people, and to allow people to provide override reasons so that we can learn from this. We also provide some education here, as well as links to the evidence for people who need to understand why we might do this. So what's really interesting about precision medicine is that the average alert that you see in electronic health records may be overridden as much as 90% of the time. With lots of tuning, people are able to get that number into the high 60s. But it's mostly the case that alerts that show up are not relevant to every single patient. With precision medicine, it's very different. These alerts are likely relevant for the patients for whom they fire. And so when we studied how well this alert was attended to in our EHR, we saw that around 58% of the time, the alert was attended to with a change in medication ordering. About 30% of the time, the alert was not was attended to, but all total for intermediate. I'm sorry, I'm saying the wrong thing. For patients who had high metabolite, for poor metabolizers, about 57 or 58% of the time, the alert was followed. For about 30% of patients who were intermediate metabolizers, the alert was followed. And the reason for that, we have determined through qualitative research, was people were confused about the fact that intermediate metabolizers, in fact, have the same risks as poor metabolizers. They simply didn't know. And not surprisingly, for patients who essentially had a non-actionable variant, we got roughly, and as you'd expect, no difference in their ordering practice. But what this began to teach us was that there are patients who should receive changes in therapy, and there are major needs from the standpoint of educating, as well as from the messaging in the EHR that we have to use to help them with their decision making. These are the components we currently have in this project called Predict. These are the medications that we currently are using. Every patient who has had a Predict study done, I'm one of those patients, by the way, gets a little website called My Drug Genome, which allows you to know which medications you shouldn't receive in case you're going to an environment that's not Vanderbilt. We also then have a series of alerts like these that are in Epic. I think you all have the same functionality. I don't know whether you've turned it on or not, because this is functionality that we kind of baked into the 2017 release of Epic. It was a condition of us accepting them. So pretty exciting pharmacogenomics infrastructure that we all now have, although somewhat complex to set up. And we're working on ways now to simplify that process. So what's the radical change in precision medicine? Well, we all know that there's a lot of new data that are coming, and that these data are going to be integrated to various extent in both the research that we do and translated into practice. And those data include genomics work, image work, metabolomics, everything that you see on the slide, including Fitbit technologies and mHealth technologies, which are the subject of, I know, some research going on at Penn as well. We're also getting more and more interested in patient-reported outcome data, and all of these data will likely be attached to longitudinal warehouses and data lakes that can be used to help generate precision medicine. One of the most recent projects at our place that combines patient-reported data with our EHR data is a new predictive alert for suicide risk that we have been studying for about a year. I show here the ROC curve. Most physicians have absolutely no idea what to do with an ROC curve. And so part of the challenge that we now have is taking this and developing the right threshold to make suicide ideation alerts in busy settings like emergency departments. So this begins to uncover the challenge that we're going to have with precision medicine, which is how we actually align what we would like to see happen in practice with a bunch of busy and occasionally burned out clinicians and EHRs that may not be as able to do this kind of workflow aligned decision support as we'd like. And this is an active area of research for me and others around the country. COVID-19 obviously brings up an entirely new challenge. We are slowly starting to understand some of the long-term, likely long-term sequelae of patients who have become positive with coronavirus. And if you have SARS-CoV-2 and you have any of the long-term sequelae, how do we keep track of those patients? How do we use prediction to make sure that they don't have to come to us with problems that we should have been able to actually predict and hopefully mitigate? More opportunities for precision medicine down the road that we're thinking through. What this brings up is that a big part of the future vision that we all have to now have is, what is it that we can do less of? What is it that we need to re-engineer to remove from a very busy and occasionally burned out health system? Eric Topol, who has written a really terrific book called Deep Medicine, wrote in the last chapter of this book the importance of recognizing that as we move forward with precision medicine and as we move forward with augmented artificial intelligence, we will undoubtedly find new time in clinical care to do other things. And it's going to be up to us to decide whether that time is brought back into the care of the patient or brought into increasing the volume and therefore revenue opportunity in practices. And I think a big part of what we now have to think about in healthcare is how to combine what we're doing in data science with what healthcare clinicians and patients actually need from us. So what else can we engineer out? Well, just in the interest of time, clearly one of the biggest things now is refuting racist myths. I'm sure your hospital, like ours, is looking at some of the data around things like this wonderful piece by Neil Poe about Black kidney function mattering and data that around the GFR and the fact that we've used race as a construct to be a proxy for biology, and that is not an appropriate way to do things. In the era of data science, and Howard Bachner, who did a wonderful podcast about this, talks about it. In the era that we're in now, while it's probably the case that there is a signal for which being Black is a proxy, we should be able to do better, whether it be by using ancestry-based data or simply looking for better biomarkers to determine patients' outcomes based on GFR, and using that, which would be a clear biological signal, rather than something like race. So there are numerous examples of this that are now coming up, and you can expect that this is kind of version 1 of precision medicine. You can expect that as we move it out of the system, we're going to be bringing in, hopefully, more truly biological signals that are true biomarkers to help us manage disease. I think I have time to show this. So this is my electronic health record. I find the easiest way to describe some things is just to show parts of my life. So this is my electronic health record. And any of you who are trying to figure out what's going on with me will struggle with this. And that's why I'm confident, because systems like the ones we currently use are incredibly noisy. And one of the things that we have a problem with is foraging, the idea that somewhere in this record, there exists really important information for each subspecialist. So what if we do something a little different? And I'm going to show you just a little hint of this, which is something that's now live in our system. I'm bringing up a shortened version of my record, and I'm clicking on a viewer for a set of tools that we've built that are running outside of Epic but are displayable inside. This is one called the word cloud. And in this version of it that I videoed, you can't see a difference in font size, but in the version that we now have, there is actually a font size that shows up as things are more and more frequent in the record. You can see now that as I scroll across the top, each of those little lines represents encounters that I had with the clinical system, and more things show up in my word cloud. So by scrolling back and forth, you can get a general sense of what's going on with me. Also, as you click these, any similar findings in the entire electronic health record turn red, along with the finding that's been clicked. So this is in the earliest phases of us exploring it. It has a ton of features. We are now in the process of testing this with some clinicians at our place to determine what really helps to tell the patient story versus what is additional noise. It's being used quite a bit right now by our finance group. But the central idea is full concept extraction of the entire health record. Again, tremendous amounts of late binding work, getting back to the beginning, that then allow us to do very clever things with these fully computable parts of the record. What you're seeing here is, as I click on certain pieces of information, the notes that are related show up on the right side of the screen. Last thing I want to show, so we've been trying to make it easier for people to get the patient story. We've been trying to use data. Just again, in the interest of time, since we've got about 4 minutes, we've also been working on tools that allow us, and I'll just show a second of this. Actually, I won't show it. We've also been developing some tools that allow us to help search the medical record using voice. So we've gone back to our speech recognition work. We now are able to ask our electronic health record things like, tell me about this patient, and get an automatic summary based on some of the key word cloud findings that's generated by the computer and read by the computer to the person who's asking. So we think this is another way that we could imagine making search much more efficient. A tremendous amount of analysis is going into how to do this well, how to make it personalized for each provider and each practice type. So a very exciting time in terms of how we can use these data. So in conclusion, where we are with the EHR is a product of significant early systems engineering and evaluation that has led to a lot of policy change. We now have a powerful platform, data, and methodologies that can deliver value to multiple stakeholders. Burnout is a huge issue and needs to be a focus of the systems engineering and the innovation that we need to enable radical change based on data science. So I'd love to answer some questions in the 3 to 4 minutes we have left, and I can stay late.
Well, wonderful, Kevin. I don't know if Ravi is still here and wants to.
Sure.
Or Kevin, you can look in the chat yourself. Or go ahead, Ravi, please.
Oh, Kevin, thank you so much. That was really great. I posted my question on the chat, but I'll just read it out aloud if that's okay. So I was really inspired by the.
I see it.
Well, I'll shorten it. The iceberg slide where you talked about the EHR opening up endless possibilities. That's very, very fascinating. My question is that pretty much everybody can get up to speed with AI and ML these days, and it starts really young, perhaps high school, perhaps even middle school. Every budding entrepreneur who wants to play in the health tech wants to get access to EHR data. Perhaps you could maybe provide your vision on how that's possible, given the data ownerships with health systems. On the one hand, it would be great to have some of these kind of open, but on the other hand, of course, there's privacy and things like that. So what's your take on that?
Yeah, it's a great question. It's not just the issue of access here. So I agree with everything that you said in terms of databases like Mimic3 and others that are available to let people do interesting experiments. The problem is that health data are a tricky animal, right? I mean, there are issues with things like veracity, right? So there's any attempt to do temporal reasoning in health data needs to understand that it's not consistent across even labs, right? And so as people are starting to think about what we can learn and start to predict from health data, I think it's extremely important that they understand the data. So while I'm really excited about seeing people use the data to develop their methods, I think that one of the things I'm trying to show is that there really needs to be very strong collaboration between clinicians who understand the nuances of these data, everything that relates to all of the V's you and I know in terms of volume, velocity, veracity, vulnerability, and then of course the privacy issues. Every one of these data sets is highly biased. Vanderbilt's an academic medical center. Vanderbilt has, we're a quaternary care center, as is Penn. We are likely not to have as much primary care in some settings as other places, which means the data themselves will be inherently noisy. There will likely be large gaps because people may choose not to deal with Vanderbilt's parking. They may choose to get their care done elsewhere. So any analyses that are being done that require a longitudinal look are simply going to have holes that will not be clear unless you actually try to combine claims data and EHR data, because claims data will at least give you a general sense of where there may be holes. So I think it's, there's a reason why people like Zach and others are teaching courses where 400 plus people show up. And it's because this is actually hard. I want people to learn the methods, but I want them to recognize, as we've all learned with biostatistics, that it's really good to have a biostatistician around and not to pretend that you learned it all from your book.
Notice Bill Hansen, you made a comment too. Did you have a question as well?
No, not really a question. I just think, hi, Kevin, how are you?
Hey, Bill.
I think that the word cloud, I think there are probably a range of tools where you could facilitate what you're talking about in the way of foraging, which is something that we all, like to do and probably are doing less of because the way to go about it is so challenging in EHRs. So I just want to call that out.
Thank you. A lot of work needs to be done in that space. And medicine is still very much a cottage industry. So the extent to which we would like to develop one engineered approach will solve at most the needs of just a few of us. And I think a little bit of this is understanding how we can personalize at the provider level, things like the information needs for particular types of visits. I hold out promise that through data science, we'll actually be able to do the provider-based prediction as well as the patient-based prediction. This whole WordCal project has a component that I didn't talk about, which is bootstrapping the actual word cloud itself, so that if you're a pediatrician and if you are seeing a certain type of patient, you would certainly want to emphasize those things that are likely to be a part of your decision-making versus what an ophthalmologist may be seeing. So there's information that we know as metadata are hidden within these data that we need to use to improve how these interfaces are visualized. So thanks for asking that question.
Yep.
I see a couple of questions here that relate to, would the EHR visualization tool be available for research? And the answer is, let's talk about it. I think the answer is yes. Will it be sold through Epic? Really long answer. The bottom line is not yet. Epic is not a big fan of managing content for legal reasons primarily, and we can talk about that offline. Let's see, I see comments. Brian, am I missing any questions that, let's see. Would love to discuss with your team working on the foraging problem. Yeah, we just talked about that. Any other questions?
There's one question, I think it's by Shadi Ahmad. It states, what has been your experience with implementation and the setting of conflicting perspectives by providers and administrators, in particular billing administrators?
There's never, ever any conflict there. I don't know what that question's about. Yeah, so I think it has helped me to be on both sides of that particular debate, right? And so my experience with this, and we talked about this a little bit earlier, Zach and I and others, my experience has been that the number one challenge there has to do with the fact that these two groups simply are we and they together. They do not work together as a group. What we found in the process of the work I've done is by bringing those groups together, we can at least understand the two competing priorities and try to see if we can find some middle ground. It's never going to be easy. Healthcare is moving incredibly rapidly. And I think the fact is that if you don't have an executive sponsor, as a phrase that I'm almost tired of hearing, but we hear it all the time, some of the most innovative and interesting ideas won't go forward. What Penn's done very well through the various ways in which innovation shows up either on the undergrad or graduate campus through Penn Health Tech, Pennovation, et cetera, is start to bring some of those people together and to bring enough leaders in the room that they can align with some of the fiscal realities and some of the timing realities of a clinical enterprise so that you can, in fact, have those two groups work together. But it's a hard problem.
Kevin, I had a quick question. One of the exciting things for Penn is the opportunity, because patients go between Penn and CHOP, is to really look at diseases and information across the whole lifespan.
Right.
But the institutions, do things quite differently. I mean, what do you think about opportunities for that? How do you conquer the pediatric adult divide? The records are different, things like that.
Yeah. Let me ask one question, if I could, Brian. That'll help my answer. Did Penn make the decision that CHOP would have a completely different instance of EPIC from HUP?
I think they're two very separate institutions united by the university. I think the CHOP people could answer, but first reaction is that Penn doesn't tell CHOP anything.
Bob, is that correct? Two separate instances?
Yeah, it's a very long bridge between CHOP and Penn, unfortunately. So yeah, CHOP has a separate instance, and the records move to the extent Care Everywhere moves things back and forth, but that's it.
So in institutions that have had this problem happen, and there are others, Stanford is among them, many of the children's hospitals, Boston, et cetera, I think one of the first things people do is they use groups like the informatics group on campus now to create longitudinal databases that could be used to at least provide a window into the information on the other side, even if it's not necessarily available at the time you're seeing the patient. So one option that one has is to use non-real-time access to longitudinal data across both sides. EPIC does actually support that. There would be a way that you guys could mirror, and don't want to get into too much of this, but there's a way that you could mirror your instances of Clarity together so that you could create one view that would actually not be the production version, but would be a version of it. EPIC themselves, interestingly, does that as a system called Cosmos. And so there is a way that you can get to some of those data. But in real time, the only way to do it is to either externalize the data and to use web services, something called FHIR, to sort of make sure that information from one side that needs to be on the other side can be shown, or to work to figure out a way to get the two institutions to share more data. It's, again, you're asking me all the toughest questions you could, which is great. I think a lot of these are people and process questions. They're not technology questions. Sorry, I can't give you a better answer.
No, thanks. You didn't blow yourself up with that question, so that was awesome.
Yeah, thank you.
Well, Ravi, what do you think? Shall we call it a lecture?
Absolutely. It's your call. You're running the shows.
No. Kevin, I can't thank you enough. It was really exciting and great fun. So we really appreciate it. And we'll make sure if anybody has burning questions, they'll know how to be able to find you.
Please do. It's kevin.johnson@vumc.org. Happy to answer any questions.
Great. Thank you so much for joining us.
All right. Nice to see everybody.